So welcome to HCRF Talks COVID with Dr. Platanias. This is session 5 with Dr. Platanias, and today we have a special guest joining us, Dr. Eleanor Fish, Professor of Immunology and Associate, International Collaborations and Initiatives from the University of Toronto. Welcome. Thank you for being here, Dr. Fish.
My pleasure.
Also joining us is the Hippocratic Cancer Research Foundation. We're all here because we're concerned about COVID and we care about cancer patients. Before we begin, I want to give everyone a bird's eye view of Dr. Fish's many accomplishments. First of all, I don't know if everyone knows, but she's a world-renowned immunologist, and in 2003, she led investigational studies to look at the use of interferon to treat SARS patients. Her clinical studies showed that patients had improved therapeutic responses to these interferons. Because of the success of those studies, Dr. Fish went on to study the use of interferons to treat patients with other emerging viruses, such as Ebola and Middle Eastern respiratory syndrome. Besides studying host pathogen interactions, Dr. Fish has played a pivotal role in understanding immune mechanisms that are involved in autoimmune diseases and cancer. Today, during this COVID crisis, Dr. Fish has been in the spotlight because of her work. Her encouraging results show that interferons can be potentially used to treat patients with COVID-19. Her studies are in collaboration with Wuhan hospital researchers and show that there's hope for using these interferons to treat COVID-19 patients. And today we look forward to hearing about those studies.
Great.
Dr. Platanias,
let me just say also that I want to thank Eleanor for coming. Eleanor is an exceptional scientist in the virology field, and she's also a very good friend and collaborator for many years. We have done many years of work together on interference, but Eleanor has really made a huge difference worldwide by trying in hotspots when viruses emerge and starting clinical trials, including Africa with Ebola, and now in China with COVID. And she has had a significant impact to the point that the African, National Medical Association invited her to be an honorary member, and she has had many different distinguished awards for her work. So and she's really one of the few experts this moment in the world on what's going on with COVID, and she has a different approach coming from the real virology field, in contrast to us that we are cancer doctors. So it will be, I think it's going to be a very interesting conversation. Absolutely. And Nicole, do you want to start it? So thank you, Eleanor.
Sure.
Again.
My pleasure.
So I think just to start off, since we all know that a vaccine is not in the imminent, present future, tell us about the hope with these interferons in treating COVID-19 patients.
So maybe we should step back a moment and just consider what's happened since essentially the end of December 2019, when COVID, the SARS coronavirus 2 infection spread globally. So there was an incredible push to examine the potential for a number of therapeutics. In other words, treatment regimens. Distinct from a vaccine, which is protective, we're looking at treatment regimens. And there's been a real explosion here. Some completely novel discovery or novel therapies, which are going to have to go through the whole process of development and phase 1, phase 2, phase 3 clinical trials, monoclonal antibodies, and these are factors that bind to the virus and essentially take it out of the system so it can be no longer infective, to a whole range of different drugs that block different stages of how the virus multiplies, replicates. And some of these have turned out to be interesting, and others have, I think I can say, under the cone of silence here, have bombed significantly. And indeed, there have been drugs, the considerations of chloroquine and hydrochloroquine, and really the emerging data, which has been peer-reviewed and published in journals like the Lancet, which is a really top-notch, high-caliber journal, you know, the data suggest there's no advantage because people respond in the same way that they do to placebo. So honestly, I think we should take chloroquine, hydrochloroquine off the table.
What about Remdesivir that's being repurposed, like for
right,
like
so
Ebola virus?
Remdesivir is another drug. Again, you know, the preliminary data suggest it's interesting, but nothing remarkable. And I think that's what the disappointment continues to be, that there's no panacea, there's no bullet that's absolutely remarkable. And I think probably the same way with so many other virus infections like HIV, where you actually come in with many drugs that target many different facets of the virus, that's where you're able to eliminate it. So let's cut to the chase here. You know, my bias, and I think hopefully Leon's is as well, is that interferons are what we should be looking at. And I think really they're the front runners with Remdesivir. You and I, in response to any virus infection, doesn't matter whether it's a respiratory virus like coronavirus or flu, doesn't matter if it's a virus that infects our livers like hepatitis or Zika that goes to the brain. The very first thing we do in response to any and all viruses is we make interferons. And viruses have co-evolved to actually block that interferon response. So they have co-evolved to encode in their genes factors that very specifically block interferon production. So that should tell us that they're important. And SARS coronavirus 2, the one that causes COVID-19,
what's going on?
Does exactly the same. It encodes in its genome a factor to block interferon production. So put that all aside, what we did was we went into Wuhan, treated some patients with interferon, and we accelerated the clearance of the virus from their upper respiratory airways. So they got better sooner, in a nutshell.
So do the drugs redirect a patient's own interferons to fight the virus, or how do they work?
So if you understand that the virus blocks interferon production, okay? Mm-hmm. So everything's swung now in favor of the virus and interferon's down here. If you come in with interferon, you can tip the balance the other way. And interferons do multiple different things. They target many different stages of the virus's life cycle, and they boost an immune response to clear virus. And that's why we always make interferons in response to virus infections. So they're really go-to.
So have the interferons been shown to help ameliorate the disease, or like treat patients with severe disease as well, or like what have you seen?
So there are now a number of trials that are going on. What we did is we treated patients really at the start of the outbreak, and in Wuhan, China, every individual who was positive was taken to a treatment center or a newly developed what they call shelter hospital. And we actually were involved in evaluating treatment in cases that were moderate. So they weren't severe cases. Subsequent to that, my colleagues have been looking at some severe cases and they've got good outcomes, but that hasn't yet been published. The reality is the sooner you can treat a patient early on in their disease, the sooner you can clear the virus, the less likely that you're going to have all those subsequent events which are really, very damning. And then the virus spreads to different organs and you get organ failure. So the notion is to treat early and treat aggressively with interferon.
Okay.
So if I may add here, just to clarify, interferon is a part of our immune system, is a substance that our immune system releases to go and kill viruses. And COVID virus has been very smart and goes and blocks this release, shuts down the immune system from doing that. So the studies of Eleanor, and I think one more group, right, Eleanor, saw that several, yeah, they have shown that interferon can be used in COVID and has some significant effects. Of course, the problem with interferons, and I worked in the field for many years, we collaborate with Eleanor, is that it's not a very easy thing to take, you know, like it's injections, and there are some toxicities. So that has been the limiting factor for interferons. But so far as I'm concerned, is the only thing that has significant activity that we see in a convincing way. Remdesivir has some activity too, and it was an important paper, but it's all very marginal. We haven't seen any drug that really blows up the body, and neither does interferon.
Yeah,
Yeah.
So we cleared virus on average 7 days faster than if you didn't have interferon. With remdesivir, it's about 4 to 5 days faster. But as Leon says, you know, that there's nothing that's absolutely profound, and that's because this is a very successful virus. The reality is that it infects many different cell types in the respiratory pathway, and then it can spread to attack the liver, the kidney, the heart, the blood vessels. I mean, it's a very effective spreader in the body.
But
So
the
it's
good
really
news is, yeah, go ahead, go ahead.
I was just going to say, it's interesting that you say that it's best to give these interferons early on to the patients. So it just emphasizes that our testing has to happen in conjunction to make sure you identify the patients that need it, right? So, you know,
so something else
that's really encouraging.
Yeah, you're absolutely right. Testing and contact tracing is so important. I mean, I cannot stress this more strongly. Unfortunately, in Canada, we have been too great at that. Those jurisdictions that test and contact trace best do really well. But the other point about interferons is that they have a potential to be what we call prophylactic. In other words, if you've been exposed to somebody who is infected with the virus, whether you're a healthcare worker or this is a family member, it's possible that if you have a low dose interferon, that will protect you from actually becoming infected. And one of the things that I'm involved with right now is doing some of what we call those post-exposure protection trials. So we're going to see is if in healthcare workers and in families where there is an individual who's been infected and they're all isolated, whether we can either reduce the severity of disease by giving the individuals interferon or completely protect them from becoming infected. So this
if you were to use them prophylactically, would it be in a low dose of interferon, or like a lower dose or than patients with the disease?
Yeah, so one of the points that Leon mentioned is there's been incredible reticence to even consider interferons because they were used a lot for hepatitis C, and this is a chronic virus infection and people stay on interferons for years. And associated with that, there have absolutely been adverse events, and you know, staying on any drug for any period of time is not a great thing, right? With these acute virus infections, we saw this in SARS, we saw this with Ebola, and we've seen this most recently in Wuhan with COVID-19. When you treat patients for 10 or 11 days with interferon, they really don't demonstrate or have those kinds of adverse events which would make you nervous to treat them. Patients who have nasty virus infections tend to have fevers and chills. We didn't make it worse when they had interferon. So I think many of those adverse events at full dose, when you have a virus infection, we don't see them. Now, treating healthy individuals, we have to be cautious, and I think we will drop the dose. And those are what the trials, what we're doing is what we call dose response. We're using different doses to see what's well tolerated and what might be effective at protecting from virus infection. We'll see, don't know yet.
I think you just answered my question, but I know a lot of patients who were treated with interferon for late stage melanoma, like stage 3 or even stage 4. And they, in many instances, have very severe side effects, not only the acute type of things you mentioned, but some skin, in some cases, skin falling off, and a very toxic treatment. Is the difference one merely of dosage and length of time?
It's a good question.
So I think I'll leave Leon to answer that. I mean,
Yeah, I think that's a very good question, and is absolutely the case. Patients with melanoma and some other tumors who get interferon get much higher doses, and at the higher doses that interferon is used is quite toxic. So that's the universal experience. In melanoma, there was a study that had shown that interferon decreases the chance of melanoma coming back if you give it for a year, but it was so toxic, it was very hard to get through for so many, for patients. So for virus, the doses that are used are smaller, and we know, for instance, interferon is used in hepatitis. Now there are better drugs that are more effective, but it was being used for a long time for hepatitis, and it was lower doses and very well tolerated. So I think Eleanor is talking now in the case of COVID and other viruses at the lower doses that are more tolerated. So that's the big difference from the interference in cancer. But still, because of the toxicities, and doctors know that, they know that patients with cancer, it was very toxic, they're very hesitant to bring it to other parts of medicine. And that's why you don't hear about interferon in the news. That's probably the most active, maybe, at least one of the two, together with remdesivir, most active agents, but people don't like to talk about interferon because it has the name of being toxic, So I think that's where we are, So that's a very good question, though. Let's open it up for questions. Anybody who wants to ask a question, please go ahead. Either Eleanor or myself will be happy to answer.
So I have just a follow-up question. I know that Dr. Fish is doing some studies to look at differences between men and women in terms of severity and incidence of disease. And we've heard that COVID-19 male patients are twice as likely to die from COVID-19. What have your studies shown in terms of why that might be happening? Does it have something to do with the immune system?
yeah, so this is something that's really not studied very much. It's beginning to get more traction. But the reality is that women have a much more, females have a much more robust immune response than males. And that's possibly because females carry the fetus and they nurture the young, and you need them to have that ability to fight off infections. So the plus side is, in response to very many different viruses, females mount a much better immune response. They have larger numbers of certain immune cells. So there's an immune cell called a T cell in our bodies. We have many more T cells than males, which allows us to mount a much more effective immune response to virus infection. The flip side of that is, for certain other diseases, autoimmune diseases like rheumatoid arthritis, like lupus, because our immune system, females, is so robust, it tends to flip us towards having more autoimmune diseases as well. So there's pluses and minuses. It's related to the X chromosome. Females are XX, male are XY, and many of those immune factors are on the X chromosome. But the likelihood is that because of a more robust immune response, females will do better in response to clear viruses such as coronavirus. And there's been good evidence for this for a whole number of different viruses, that females clear them better. And indeed, when you think about vaccines, a vaccine is a little piece of a virus that you're given, right? And females mount a much better immune response to vaccines than males. So you actually can dose spare vaccines. You need less of a vaccine to get a really good response in females than you do in males. So yes, in answer to your question, Nicole, we're not really surprised that females are faring better and getting less severe disease, because we understand that the immune system of females tends to be more robust than males.
I'm not just saying this to score points with my wife, but we all know that women are much stronger and tougher than men. We had a couple of things that we've discussed in other episodes concerning the fact that this particular virus seems to attack people who are obese and with diabetes and heart conditions a lot more strongly than other diseases. I wanted to sort of get your take on that, and then your take on whether or not somebody who has been exposed to COVID-19 actually will build up immunities to it. Because in the general literature and press, you know, there's speculation that it will, but no empirical proof on this.
So we know that if you're in any way what we call immunocompromised, again, Leon can talk to that with many of his cancer patients, but if in any way your immune system is compromised, it's not as strong as it could be, then the likelihood of you getting a more severe infection, in other words, the virus is able to replicate and spread very efficiently, is higher. So it's not surprising that those individuals with what we call comorbidities, things like diabetes, things like hypertension, many of those scenarios, sorry about that, many of those scenarios, they tend to be more susceptible to have a progression of their disease and a more severe disease. We're learning that. And the notion is that this virus can spread from the lungs. So you were hearing of relatively young people dying of stroke because this virus is able to attack certain cells that line blood vessels and cause strokes. So yes, if you're at risk of any other sort of immune dysfunction, or you have anything that affects your ability to mount a good immune response, then you're more susceptible to more severe disease. And I've completely forgotten what the other question was.
Just dealing with building up immunity by having been exposed to or contracting COVID-19.
Well, you know, the jury's out on that. Certainly, there are, if we collect bloods from people who've recovered, and one way to see whether they would be resistant to subsequent infection is you measure in their blood something that's called antibodies. And ideally, you measure these factors that are called neutralizing antibodies, because they will neutralize very specifically that virus. And we're seeing that for different individuals, those neutralizing antibody numbers tend to vary. For a long time, we thought, oh my goodness, they're really, really low. So you're going to be infected over and over and over again. But now we're seeing that's not necessarily the case. As we learn more about this infection, we find that, you know, the time to recovery is much longer. So the time to actually be looking for those blood antibodies probably should be a little bit later. So there may be good antibody titers that will allow us to be protected from subsequent infection. But again, that's going to be influenced by a number of factors. If you're younger, you're going to probably have a better antibody titer than if you're older. If you're immunocompromised, it's going to be not as good as if you've got a healthy immune system. So there are many factors that come into play, and right now we still don't know how well the antibody response or that immunity to subsequent infection is until we've sampled more and more and more people.
But the reality is that most of the people who get the virus, that's what they will develop some immunity, some. The question is how strong the immunity will be and for how long it will last. For some infections, you get immunity for the rest of your life. For some, you know, it can last only a few months. So I think that's where it comes down to it. You know, So there is a lot to be learned, but I still think it is expected that most people will get some immunity, although we cannot define how good will it be. But there will be something, you know, most likely.
The other issue here is that this is a virus that's already changing over time. It's called mutating. So
Not that much though, right? Not as much as the flu virus. That's the
no,
difference.
it's nowhere near as much as the flu virus, absolutely.
Yeah.
But
Yeah,
that will play into the immunity that we get also.
Right, right. Yeah. I think my opinion is that the best way to stop this virus is for everybody to wear masks. If we get to the point that for going forward now as the country is reopening, people wear masks all the time, then this virus will have hard time to keep going, because that will stop the transmission both ways, and it has to be for some time. But I think that's the critical piece. The virus spreads so like a wildfire, because at the beginning, people were assuming that people who have no symptoms cannot transmit the virus. Now we know that you don't need to have symptoms to transmit the virus, meaning that people may have no idea, but just by talking to someone or just by being close to someone without any symptoms, they may give you the virus. So the only way to stop this, unless there is a vaccine, is to wear a mask. Everyone to wear a mask, because in that case, the people who have the virus cannot give it with a mask. So and I think that has made already some difference, because now people wear masks in hospitals, in stores. This is an important part of stopping this pandemic, you know.
Well, and Eleni and others are making fashion statements with the mask. But
yeah,
I'm wondering, you know, there was some talk before that perhaps the West Coast version of the virus was different than the East Coast version. And we know in cancer, one person's lymphoma is not necessarily the same as the others. There's, you know, it's individualized and there's different forms. But so far, it sounds like you're thinking that the mutation of this virus is not to the point where, you know, a treatment that may work for some people won't work for others.
Absolutely. So most of the treatments that are being looked at are target, you know, some of the features which are not going to change. I mean, this virus gets into cells in a very specific way. So there are those groups that are developing a way to stop it entering cells. And the virus has to get into the cell that way. So even if it mutates, it's going to keep that process intact. So it's targeting those features of the virus which are not going to change, that are required for the virus to be what we call fit.
Dr. Fish and Dr. Platanias, can you just enlighten us with what makes this coronavirus more infectious than other viruses we've seen in the past, like SARS, or, I mean, we've heard it be historically compared to the Spanish flu. So, you know, going into the future, it's very daunting, and it's because of how much more infectious this disease is compared to previous ones. What makes it so infectious, this coronavirus, compared to like SARS or something else?
In actual fact, so there are two things here. So people are always comparing this virus to SARS and saying it's actually much worse than SARS. It actually isn't. The reality is with SARS, certainly in Canada, it never got into the community, so it never spread, okay? With this particular virus, it established itself in the community very quickly and spread. So we had community spread. And once the virus is in a community, it's very difficult to stop its spread. For SARS, it was in the hospitals and very few cases that actually were in the community. So it was stopped in its tracks.
That's interesting that you say that, because I was in Toronto at the time when SARS happened. And I remember we'd have to wear masks in the lab and everything, but there was never that fear of it becoming what is today. So that's interesting for you to say that.
It was never in the community in Canada. The other thing is, what So the disease is actually less severe than for SARS, and people don't realize that. It's just we've got such huge numbers of cases that if you do, a 1% fatality rate, if you've got only 10 people or 100 people, it's just one person. If you've got 10,000 people, it's many, many more. But severity is much less than for SARS. You should keep that in mind. But what is remarkable about this virus is it multiplies, it divides much faster than SARS. So SARS, when we compare, you grow SARS virus in cells and you grow SARS coronavirus 2 in cells, this rate of growth is much, much faster than SARS. So, it's what we call replicating, multiplying much faster. So you add that to the fact that it's in the community, so you get much more virus around. So that's probably contributing to the large numbers that we see.
What is my personal worry is cancer patients, because there are some cancer patients who stop their follow-up. Some of them, not so much the follow-up, we call them, we engage them, we make sure that we follow up. But there are some others who may not have gone to the doctor, may have a symptom and they ignored it because they were afraid of the virus. And I have been trying to make the point here that, for cancer is a very serious disease. It's not any disease that can wait. In some cases, so we have been making the point that cancer patients need follow-up, and we've been trying very hard to accomplish this. I think right now we're entering a new era where we're going to have a transition. Now the hospitals are opening, the society is opening again. And I personally think this period of isolation, although it was very difficult for everyone, from doctors to patients to everyone, it was important because it stopped the risk was that the healthcare systems will be overwhelmed, as it happened in Italy and Spain and in New York. At least this was controlled. And now I think we understand better. We know how to wear masks, we know to protect ourselves, to avoid people. So I'm much more optimistic of what will happen now that things are opening again. And I hope that we will have, as long as people keep the important things, wearing masks and keeping their social distance, I think I'm cautiously optimistic that we will be able to decrease the impact of this pandemic, because it was very painful all these times, all this isolation time, I see Dr. Chu. Yeah, go ahead.
Dr. Platanias and Dr. Fisher, can I please ask you a question? Yesterday, Dr. Fauci announced that there is the vaccine that they have tested in the monkeys, which is very promising. He was very optimistic of saying in the news that hopefully by the end of the year, we will be vaccinating thousands of people. And then he said, likely the coronavirus isn't going to be a long duration immunity. Can you make us understand why did he make that comment? If he says that this is a very promising vaccine, that he has been working on monkeys, it has been working on people that they're trying it on. So why would he make a statement like that?
I don't know. Eleanor, do you want to take it, please?
Yeah, nothing is simple in this vaccine world. So vaccines, they provide you with that protection, and depending on the potency of a vaccine, you can have protection, as Leon mentioned earlier, that might last a lifetime. And again, it depends on your age, but let's say you're a young person, as a child, you get vaccinated. Many of these vaccines afford you lifetime protection. But some vaccines don't have that quality that you will have lifetime protection. So you might have to get boosted more than once. We don't yet know with the vaccines that are being developed whether you'll need more than one dose, how long that protection will last. This is all a big unknown. And short of infecting people purposefully with the SARS coronavirus 2, we're not going to know. So we can measure, as I mentioned, those antibody titers and show that we get a good response. And that tells us good. You know, in monkeys, they're giving a good response. That means they're going to be protected. We infect them. We're not talking about infecting thousands of monkeys, right? This is a handful of monkeys. These are very carefully controlled experiments. And the data, according to Dr. Fauci, are promising that it protects them from subsequent challenge. Nobody's looking right now because we haven't had the time to see whether it protects them 6 months from now when we challenge them again, or a year from now. So the answer is, I don't think we really know. In the short term, he has implied that the vaccine is effective and protects in the short term. But we don't know just because those experiments haven't been done, because the vaccine hasn't been around long enough. So those same monkeys that have been vaccinated, if they're challenged in 6 months from now, maybe they'll also be protected, or maybe they won't. We don't know. I think that probably is what is unfolding. So let's wait and see.
Can I also ask you another question, please? Is there any statistics? Why were there, in the beginning, they said that people with an underlying pre-existing condition would get the COVID. Then they said people over 70, 80 were more accessible to getting the COVID. Then all of a sudden we hear of young people dying from aneurysms or heart attacks, all related to COVID. Is there anything, any kind of data that tells us why did it strike, like in Italy, for instance, or the elderly? Why it's so random the way it strikes ages in different parts of the world?
I don't think it is random, if you want to know the truth. I think just the numbers of people who've been exposed to the virus are so huge that we're learning in the elderly, they get a more severe disease because their immune system is not as strong as young people. In those who have what we call comorbidities, they're weakened by other diseases, they have a more severe disease. Now we're learning, just because of the huge numbers of cases, that there are certain individuals who, as you mentioned, have strokes. We would never have known about this if there would only have been 100,000 people infected. Because there have been millions, we can now see that a number have had strokes. So it's only because of these huge numbers that we're able to see aneurysms in some cases, strokes. The elderly don't do well. The very young develop this, what's called a Kawasaki disease syndrome. And it's only because there've been such huge numbers. It's probable with other coronaviruses like SARS, if we would have had 4 million people globally infected, we might have seen similar things. But we didn't. So if you have only 1% of the 4 million that are infected, that have this strange scenario, you'll see it. If there are way fewer people, you won't see it. So I think it's a numbers game that we're seeing. Because there are such huge numbers, we're seeing lots of different kind of scenarios in terms of what develops and what the outcomes are. I don't know, do you want to comment on that, Leon? Do you think that's...
No, I agree. I think, however, there is also, there is a significant number of cases, about 20%, get some serious complications from this disease. And that's more than what the flu does. Is, like the same way SARS is a bad disease. This is probably not as severe as SARS, but there is a significant number of people who get very serious complications. Like even people who recover from the unit sometimes get serious lung damage that is long lasting. So it is not, the other things that we see, the more rare stuff, like the strokes in young people or the syndromes in children, I completely agree. These are rare events, but there is a pattern with this virus. These thrombotic events, the very high incidence of infecting the lungs, that we don't see these things with the flu routinely. Not most patients get, hi Jimmy, not most patients get you know, pneumonia with the flu. So it's a combination, I think, but totally agree. It's very common. That's why we see so many things.
Well, we had the 100-year-old that survived, right? She must have been from the island of Itaki, so we all have to go there.
The other thing is that most of us have been infected with coronaviruses. You've had colds. Most of us have had colds. It's a very mild coronavirus because it only infects what we call the upper respiratory. With SARS, with this MERS, and with this new COVID, it goes down to the lower respiratory as well. And then when it's there, then it can develop, you know, it can go systemically and attack different kinds of organs. So it's definitely a virus to contend with.
Doctor, I wanted to ask you a practical question, but a hypothetical question. For purposes of this question, I want you to assume that a lot of wonderful people, including somebody who we won't mention, but is married to a rock star who a couple minutes ago kissed her hello, put together an annual gala. And this gala raises millions of dollars for cancer research. And it raises money not just for any researchers, but for the absolute best, most brilliant doctors in the world, such as Dr. Platanias. And this gala is scheduled to be held in November. Would you recommend, A, that the gala proceeds in November with making proper accommodations such as wearing a mask and doing some spacing and proceed to raise money to save lives? Would you recommend, B, that this gala be moved forward to maybe early October and held outside? Or C, would you recommend that the gala not be held at all and people continue to die from cancer? And then as an add-on to the question, if this gala were held, would you do the people who put it on the honor of attending?
Boy, you were reading my mind, weren't you?
Who are you asking, Leon?
Yes.
No,
We're asking both of you.
because-
We're asking both of you. We're asking both of you.
Well, should I try? You want to try first, Eleanor?
I think you should go first, Leon. This is your...
Okay, so I have talked that with Eleni. You know, this is obviously the Hippocratic Foundation. This gala is an extremely important event that has made a huge difference in our cancer center in Chicago. And I'm deeply grateful to Eleni and the whole board here for supporting this effort. It literally saves lives directly or indirectly. Now, I think we should still wait and see, because again, we're still in June. I know we have to make a decision. Eleni, you were saying by August. What were you saying?
My heart has been pounding every day. It's like, okay, what's going to happen? We have to make a decision, absolutely.
By August?
By the end of August.
Yeah, so let's wait and see, because if things get much better, I think there is a possibility, and the city, we will also see what the city and the state does. If they allow events up to a certain number of people and we can have social distancing, you know, it may be still doable or it may not. But I think it's too early to call this moment. There are some things suggest that it will be hard to do it, but you never know. So my feeling is that we have a little more time to decide. It may be the first gala ever that in addition to black tie will include a black mask. I don't know, you know, that's, but there is still a chance. I want to hope there is a chance, but I think we need a little more time to make the call here, so.
So I want to compliment the first part of your answer. I moved to strike the part about delay just for purposes of Dr. Fish's response. And then with that, Doctor, like your response. And I guess the other option might be if Illinois, for whatever reason, will put ridiculous number of restraints on, maybe we hold this thing in Florida.
Hmm. That's an interesting one. How about Greece?
I would love that.
Question. Can I ask the doctor a question?
Yeah.
Hello. Can I ask the doctor a question, doctor?
Sure. It's me. Me or Leon?
Well, actually, both of you. Both of you. You know,
Yeah, Karen, excuse me, I don't mean to interject like that. Forgive me, but I would like to hear Dr. Fish. Dr. Fish, if it was up to you,
I agree with Leon.
what is your thought? Should we wait, or do you think we will be okay for November 14th to host this event?
You know, again, you know, none of us are prophets. I think a lot can happen between now and you have to make a decision in August. So we're looking at 8 weeks, and in 8 weeks you could have you know, the number of cases could drop significantly. Your politicians and public health officials might say, let's open it up to not just 50 or 100. You know, it depends on so many factors. There may be capacity that we don't have to worry about anymore. Hey, we may have interferon improved as a therapy, and we don't have to worry at all.
That's a long shot, but
Well, I don't know. You've been wearing black masks. Why not give everybody a little sniff of interferon as well?
That
I
sounds like
think
a good idea.
it's absolutely feasible that you may well be able to proceed. I certainly wouldn't cancel it, no.
Well, if we do proceed, we want you here as our guest. We'd love to have you.
That's if the borders are open up.
Hopefully they will. I'm sorry, Karen, go ahead. I'm
That's
sorry.
okay. I was just curious, you know, and a few of you here know that I'm a colon cancer survivor. I have seen in other countries where they have been like 75% vegetarian people, that their cases are less. Do we have a problem in America with the way we eat? And maybe, because I know 75% of your immune system is your intestinal tract. And
it's so funny. Let me make a point here that both me and Eleanor are both vegetarians. You knew that people know that for me, but Eleanor is also. That's why we're so good friends. I don't think there is any direct proof of that. Although I personally think being vegetarian is a healthy thing, but there is no proof that you know, being vegetarian protects you from anything like that. So I wouldn't correlate these two.
no, but
I don't know, Eleanor.
healthy.
What's that?
There's
Your
no
immune
question
system
that
is
you're,
healthy. You can fight things better, right?
Well, there is no clear evidence. I mean, I wouldn't have people stop their lifestyle because, I don't know, Eleanor, do you want to comment? You're a vegetarian too, so.
I mean, I think the reality is it's, you know, you are what you eat for sure. And if you're eating, you know, McDonald's every day, it's not very healthy. But I think, you know, that the reality is that you're absolutely right. Your gut microbiome, so what the bacteria that colonize your gut influence your immune system. We know that absolutely unquestionably. So you can change your microbiome, but to draw the direct correlate that being vegetarian means you're healthy, means you're going to not get COVID as severely is a huge, huge leap of faith, and there's no data on that. But I think it's just advisable for everybody to consider their diet seriously in terms of their health, full stop. That's my bias.
Yeah, I was just curious. Thank you.
I wanted to make a comment though. This is a wonderful discussion. Thank you all very much, Dr. Fish and Dr. Platanias and Eleni and the entire group. But for the diet, there's some studies that they show that if you have vitamin D deficiency, your immune system is not boosted as much. So vitamin D deficiency has been found in a number of autoimmune disorders, and also it's one of the factors that is seen, you know, at lower levels for those who are of ethnic skin, you know, for my work. So vitamin D is something to consider. I'm not saying, you know, just go and get vitamin D for whatever reason, but I think it's good to check it out. And I think at the beginning we were reading about a healthy diet and not to eat those foods that increase the inflammation in the body. And, you know, as I think it was brought up very nicely, there are two parts in this disease. One is the immune response. The second part is that this virus, for some reason, may attack endothelial cells, like the cells that are lining up the blood vessels. And so that's why we see those cases that they have all these tragic outcomes. They have strokes, ischemia, you know, we see on the skin like necrotic lesions. So this is when blood vessels are affected, and so they're destroyed, and therefore different organs are suffering. Blood vessels and so forth, you know.
So, Lina, I don't know if you are aware, there was a study that saw that patients with COVID who had vitamin D deficiency had worse outcomes.
Mm-hmm.
This was done here by our cancer center. He's one of our associate directors here. He made that discovery by pulling out data. He's not a virologist. He works in our team. And he was all over the news. He was the New York Times. It became a big deal. And I talked to him. We talk all the time. And he was overwhelmed with that because all he found was that, you know, it was a statistical analysis, no mechanism behind it. And he thinks, like I do, that the reason there is the association is that the degree of vitamin D deficiency may... Wow, who is that? It may be good for people to remember to mute that. So anyway, there is this association that has been published, but nobody understands it. It doesn't mean that by taking vitamin D, you stop the virus. I don't think
Absolutely.
so. But it's one of these factors, you know, vitamin D, many of us, some people have low levels. We don't go outside. We live in Chicago. But it was a very interesting correlation, and it was independent prognostic fact, unrelated to obesity, heart disease, whatever. So just going to that point.
Jump in there, Leon.
Yeah,
so
yeah.
In the context of vitamin D, in Canada, the public health recommendation is that every adult has at least 2,000 units of vitamin D per day. Being in the Northern Hemisphere, we have less access to light. And throughout the year, this is not just May to October. We do know absolutely that vitamin D influences very many immune cells in terms of their activation and their effectiveness. So that's a priori, we know this. And to go back to the business with males versus females, estrogen is very important in the context of influencing vitamin D levels. So vitamin D is, I don't want to say critical, but it's certainly an essential player in our immune response. So we shouldn't be too surprised that those that have good levels of vitamin D tend to have a more robust immune response than those that don't. And the correlate with that would be that they would be better equipped to deal with infection by a pathogen such as a virus. But nobody's actually looked very specifically at what cells vitamin D will activate to influence the progression of this COVID-19.
Yeah, this is a great point. Even in tuberculosis infections, deficiency of vitamin D played a role in the past. So this is really a great topic for more research. We had yesterday a big discussion at Chicago Derm Society. So it's, it is all over.
We do this with our MS patients. I'm sure you do the same in the States. MS patients in Canada, they 4,000 units of vitamin D every day, unquestionably.
You want to explain what is MS? You want to mention
sclerosis. So that's an autoimmune disease, multiple sclerosis. So one of the ways that we've done trials certainly in Toronto to show where we randomize people to receive a high dose of vitamin D versus a low dose. And we see that in terms of those cases that have relapses, the more vitamin, if you have this higher dose of vitamin D, you tend to relapse less often. So
I'm just looking at the chat right now, and I just have two questions for Dr. Platanias and Dr. Fish. It's from Joanne Matsakis. Are masks more effective than social distancing? That's question number one, sorry. And question number two is, can you enlighten us on what is happening in Sweden currently?
Okay, let me answer the mask first, and then Eleanor will take the Sweden first, which is the more difficult. So the masks and social distancing are not isolated, they go together. You need both of them. They are more effective, it's like 1 and 1 equals 2. You need both of them to get the best outcome. So you cannot compare them. We have to be doing both. Masks are absolutely essential if there is not enough social distancing. But the best way to stop the spread of this virus is to combine both masks and keep a distance. Nobody likes that. You know, nobody is totally antisocial to be doing all that stuff, but it's the most effective treatment we have right now, approach to prevent COVID. Masks, I literally think this saves lives. If all of us wear a mask all the time for the next few months, whatever the scientists decide, will literally save the lives of some people, directly or indirectly. So I think these are a combination, they cannot be compared. I don't know, Eleanor, what do you think?
yeah, I mean, there's no question. So the mask is to prevent, if you have the infection, those droplets from spreading. You wear a mask, it's a barrier. End of discussion. You're still going to get some virus that gets out, but it limits it. So as Leon said, for those who are asymptomatic, have no symptoms, but might have the virus, if you wear a mask, you limit the likelihood of spread. And the further away you are, the less likely you are to contract the virus. So absolutely, what we have now is physical distancing and masks. And the mask can be anything. It could be a bandana, you know, if you're a hospital worker, you want something much more effective, but you just need a physical barrier. And the other thing it does, it stops you touching your face, and then you've touched a surface and you touch your face. So absolutely, masks and physical distancing, an absolute. And it's frustrating that certain jurisdictions aren't mandating it, but it'll happen.
I just
So
want to
about
make a
And then
comment
the
about
Sweden
mask.
question. Oh, sorry.
Oh, just
Lena,
a
go
quick
ahead.
comment. These are great points, and they're so much appreciated to highlight. And also for the mask, we see many times that people just leave the nose outside and they just cover the mouth. And, you know, it's not to blame anybody. You know, nobody really enjoys wearing the mask, and none of us. But there are some studies now published showing that the cells where the receptors sit are mostly found on the nose, like the ACE2, you know, receptors, the angiotensin converting enzyme 2. So if you really have exposed this area, you have much higher chances to breathe it, like to contract the virus. So that's so important to remind everybody, have the nose covered.
Plus, you're not depriving society of anything by not showing your nose.
Can I
Yes.
ask a question, please? I hate wearing masks. I'm going to come up front and say I hate wearing masks. The other day, I had to wear it because I was in the hospital all day for doing tests. And all of a sudden, when I took it off when I came home, I could not stop coughing. Then I had to go back again to the other hospital to take some tests. And again, I wore a mask. And again, I started to cough. And I'm like, that's it. I'm never wearing a mask again. Just
No, yes, you will wear a mask.
and I leave. And I just could not understand why every time I wear it for a long time, I start coughing. Now I have sarcoidosis.
Okay. So maybe you should wear just a bandana. Wear one of your beautiful scarves and wrap it round, and then you'll look stunning, and you won't have the same reaction to your mask.
But going back, Dr. Fish, to what you said with vitamin D, my specialists are in Denver at the Jewish National Medical Center and Northwestern, a lot of my doctors. So when I went back to Denver, my doctors asked me, what is it that I was doing? Because I was a time bomb 4 months prior to my other meeting that I had with my doctors. And all my levels started elevating. And they were like, what is it that you're doing different? And I said, besides praying, I go on my knees morning and night. I go, I'm taking a lot of vitamins. And then they went down and they asked me what kind of vitamins I take. I go, I'm doing holistic, I'm doing vitamin E, vitamin D, vitamin C. And they all looked at each other and they came to the conclusion that whatever I was doing, just keep doing it.
Absolutely.
And I was out of the medicine. So going back to vitamin D, I am a person that believes in that because of my disease.
I don't, you know what? I mean, this is the medical, community is fully aware of the benefits of vitamin D for your immune system. So you're not in, this isn't complementary medicine. It's established Western medicine now that vitamin D is an important facet that we should be looking at.
And it's only $9, everyone, so go buy a bottle.
Don't they also prescribe it? Don't they also prescribe it to women that are past menopause to put it back into their bodies, right?
Everybody should take at least 2,000 units daily. That's the recommendation.
What about the people that are jogging that are told they don't have to wear masks? They have droplets coming off their body, right?
Everyone should be wearing masks, full stop.
The people who jog should wear masks.
Yes,
because they can transmit the disease, yes. And the people who bicycle too.
Then why are a lot of them dropping? I'm sorry, this was in the newspapers. They said people that were jogging, people that were running, people that were on bikes, a lot of those people were passing out. And they said it was due to masks. Is that true?
No.
I have not, most of them don't wear masks, unfortunately. I don't know where will this data come. Most people, it's very little. I don't see them.
Is a lot of people are because there's no access to fitness clubs.
Right.
A lot of people are taking up jogging and biking who perhaps have never done this before, and maybe it's just such a shock to the system. I don't know. I mean, who knows?
I think there's also this misconception that oxygen and carbon dioxide doesn't pass through the mask, and it does. Viruses are bigger, right? So it blocks those, right? So
virus can go very happily through the mask, but it's captured in the droplet. So the droplet is a barrier.
Mask.
But the mask is no way a barrier for the virus.
Well, the N95s are. That's the only one.
But I'm the one. If you're going to put this beautiful scarf around, it's not going to do anything. It's going to prevent. It's a barrier to droplets.
So there was a study that came up from New York, and in fact, it was someone who trained with us, who reported that in some groups of cancer patients who got COVID, the mortality was much higher. Like some special cancers had much higher mortality. So the whole thing has been very difficult because you have a very terrible virus out there that kills people. It affects more cancer patients. At the same time, it has made it difficult for cancer patients to get diagnosed and take care of themselves. So we have both direct damage and collateral damage, and we don't understand yet what has been the most. We need the data, as you say, Eleni. We need more data, and it will take time for this data to be collected,
Because I think that it's very prudent for us to get that data. And then we can say, you know what, we did something good for our country.
Yeah, no, I think you're right. We're trying to collect the data in Chicago, and I know that other cities try to collect them too. That will be very important to define. Now, as we are moving to the next phase, whatever happened. The good news is we are much better prepared. Now we know we need to wear masks. We know social distancing. So I'm much more optimistic than I was then about what will happen going forward. And if people stay together as a team, and they work together as all of us as partners, we're fighting a common enemy, I think this can go behind us. Look at Greece. Greece pretty much eliminated the whole thing. That's small Greece, did these things. So I think that's
we have a lot of vitamin D, Dr. Platanias. Don't forget, we have a lot of vitamin D.
And they got the best. They got the best
forget, Greeks as DNA-wise, we suffer from vitamin D shortage via our DNA, as what I've been told. So Right there, that, you know, that's not that supporting, but yeah, my husband has been stuck there since February 13th, and he has not come over from Athens. And he said they did it superbly. They locked everything down.
I was just going to say, Dr. Platanias and Dr. Fish, I think we can all agree that we're all yearning for normalcy. And I think it's been so encouraging to hear how promising these interferons might be. My question to you, Dr. Fish, is if your studies conclude, how long would it take to implement these drugs as a repurposed drug and actually use them so we can move forward even further and get to more normal?
So we can have our gala. Come on now, let's be specific.
Yes.
November 14th.
So certain jurisdictions, they are already, in the absence of what we call randomized controlled trials, the gold standard, but just based on the preliminary exploratory studies, certain jurisdictions are already recommending interferon as a treatment. Actually, China is one of them, Mr. Yolanis. Cuba is another. In West Africa, there are a number of countries that have asked me, they don't want to do trials, they want to just do straight treatment studies. Reality is that because it's already, these drugs are already approved in the US and North America and across Europe, repurpose them should not be any, that shouldn't be the limitation. It's going to be availability, how widely available they are. There are a lot of what we call biosimilars. So many of these have come off patent and companies are making biosimilars. So it's not the generic product. You know that with a number of drugs that you're aware of. So it's really just a matter of ramping up manufacturing, and that's happening in different jurisdictions. So I don't think it's going to be an issue. It may be in certain jurisdictions like North America, first world, North America, Europe, Japan, China. It's not going to be an issue. They'll be widely available. And in other areas, perhaps not. Because of cost.
Mexico.
Sorry?
What about Mexico?
Well, Mexico will be buying their interferon.
All they're going to do is buy it. Yeah.
Doctor, early on you said hydroxychloroquine wasn't a good solution. And while we're on here, I was watching TV, and one of the studies that talked about all the adverse consequences, the authors retracted their results.
Yes, I was just watching that myself while we were talking. It just happened right before we talked. So that was one retrospective study, though, that, and they retried, there were two papers retracted. One was the hydroxychloroquine, and there was another paper in a very important journal in the New England about the cardiac effects of COVID. So, and it had to do not with the author, it sounds like they were using a company, we don't know, something really bad there. But independently of that, earlier this week, there was a real prospective study that was not retrospective like that one, that they compared, they took patients who had been exposed to COVID, and some got hydroxychloroquine and some did not. And the outcome was exactly the same. So beyond the study, this study and the one that was retracted, there have been several ones. And again, if you asked me 2 months ago, 3 months ago, I told to people who were calling me, take hydroxychloroquine, because we didn't know then. But now, I think the evidence is very overwhelming that the drug doesn't work. I mean, I wish it did. But the studies that showed that the drug was working had no control groups, were people just getting it. And this French study that we're giving it together with the antibiotic is, it was really not a good study at all. There was, so I don't know, Eleanor, what do you think? What's your opinion on that?
It's extremely frustrating because there are, international bodies which still will not stand up and say, drop it, stop it. It's not effective. They're fearful. I mean, a number of drugs are still being evaluated in clinical trials, which we have accumulating evidence that they are either minimally effective or, to put it bluntly, ineffective. And I would wish that those studies would be terminated and we'd focus on the front runners. So as I've mentioned, my bias is let's explore remdesivir, let's explore different interferons. But if we focused all our attention on maybe a handful of drugs alone, in combination, on global trials, we'd have an answer in 8 weeks, because there are enough cases around the globe that we could accumulate. But if you have 150 different trials, and many of them are following up on drugs which we already know are not going to be winners, I think you can appreciate my frustration. I think I would like to hear our leaders, our international health leaders, saying, let's stop this one, let's stop that one. Maybe in 6 months from now we can revisit them, but let's focus on where we know we've got some strong preliminary evidence. And hydrochloroquine, in my opinion, drop it. This combination that was used in HIV, drop it. Lopinavir, ritonavir, you may not have heard about it, but just drop it. It's ineffective. There's another drug, ribavirin, drop it. It's ineffective. Focus on the ones where you have a good chance of success.
How about you, Lena? What do you think, Lena?
Again, I echo the comments. It's very early to conclude on one treatment. I'm not the epidemiologist or infectious disease specialist. True, at the beginning, a lot of people took hydroxychloroquine, and from what I have also heard, in Greece, a lot of physicians who were in frontline were taking hydroxychloroquine. But there is, first of all, one detail, that hydroxychloroquine has a lot of adverse effects. And so you really have to be careful to start taking hydroxychloroquine. You need cardiac monitoring, eye exams. It's not as simple. Studies show, exactly the study that Dr. Platanias was mentioning, that between those patients who were treated with hydroxychloroquine and those who did not receive hydroxychloroquine, it wasn't really any major difference. And I agree, in order to come to a meaningful conclusion, you have to be focused on certain pathways that make some meaningful results, and then continue to grow the evidence. We don't even know, as far as the immunity, as we were discussing before, for Sweden. It was not right to have everybody exposed at the very beginning, first of all, because the system is overwhelmed. And the second is that nobody knows about the immunity. And now we know that they offer, at least healthcare providers, testing for antibodies. But even though you test and you have antibodies, you're supposed to do the same thing, because we just don't know much.
So the reality is that there is no drug at this moment that we know it works well. Remdesivir is the drug that has been proposed as the best one, and that's the one that has the most activity, but it's not impressive at all. And there are several ones that I think they are negative, like the HIV drugs, hydroxychloroquine. So we need to come up with real new drugs that work. And I think it's going to take time. The interferon, the Eleanor's angle is very interesting. I just don't see it becoming like the main drug because of the toxicity factor, Eleanor. And I hope I'm wrong, because as you know, I'm an interferon guy myself. I promote interferon, we do it all the time. But somehow I think it's going to end up coming to something else that has not been developed well yet, So
Maybe we should have a bet on that.
let's do it. I want you to win. I cannot bet because I will want you to win. So,
but the plus side of all of this is, even though some people may be going down rabbit holes, the unprecedented attention and activity by the scientific community in developing potential treatments, doing studies, coming up with vaccines, and already vaccines which are just in trial are being manufactured at high dose. So if they show to be effective, they could be deployed rather quickly. I've been impressed with a lot of that. And you had mentioned, Dr. Fish, that we just needed an international organization with some gravitas to say yes, no. What I've been the most disappointed in has been the health organizations such as WHO And such is the CDC, which has been wrong so often, from testing to don't wear a mask at the beginning. What they should have said was the truth. Masks are good. We don't want you to wear it because it's more important that our healthcare providers have it. That's essential. And now, after going a long time, masks don't help, trying to convince people to wear masks. So I think they've given themselves, these organizations have undermined their own credibility. And I thank God for doctors like you and Dr. Platanias who are doing great work, because that's what's going to keep all of us going.
On vitamin D.
And vitamin.
If I could ask you, how safe is a vaccine that will be developed sooner than the 18 months mark that most scientists said in the beginning that it's the time needed to develop a safe vaccine? Because many people are wondering, you know, when they say that in 2, 3, 4 months, we're probably going to have a vaccine. Is that going to be a safe vaccine or?
So for sure, the appropriate safety trials will be done. The difference is that now there are manufacturing plants that are already scaling up ahead of getting approval. So they're risking the dollars, so usually there's a process. One
Dollars.
another.
Thank you, Dr. Fisher, being honest. It's the dollars. They're risking the dollars.
They're moved, usually it's a sequential process. And what we're seeing now is that some of these things are not sequential. So they're building the manufacturing capability. So that's why it's faster. Plus the stringency of the safety and toxicity that you can be assured will be followed through. Nobody's going to run the risk of releasing a vaccine that is going to have fatal outcomes or devastating outcomes. There are enough anti-vaxxers that's the last thing that's going to happen. It's just a matter of using technologies and platforms now that allow you to identify a vaccine and much faster and then get to the clinical trials much faster.
So if it's a questionable product, the community in large has the power to raise the voice of objection?
Well, if it's not an effective vaccine or it's not a safe vaccine, it won't be released.
Will not be released.
Safety is not going to be compromised. I mean, rest assured, nobody is going to put the public at risk in terms of safety. Effectiveness, it may not be 100% effective vaccine, but there are many of those already out there. The malaria vaccine is only 30% effective. So 30% of people who get the malaria vaccine are protected, and yet it's a vaccine that's widely available. So I don't want to say we run the risk, but we may find that the front runner vaccines that become available may be less effective than we'd like. But again, I don't know, I'm not a prophet, I can't speculate, but safety will not be compromised.
Dr. Fish, we deeply thank you because you honestly educated us.
Yes, thank you.
I admire you both and Dr. Tukas, all three of you, as great doctors, because I personally know the 2 out of 3. Hopefully one day I will get to know you too. And I have to say that we are deeply indebted to you, all of you, for being in the front line, first of all. Second of all, for being so compassionate and empathetic in trying to resolve this mess, where all of you are putting efforts in that extra mile in trying to pull everyone together. And I just hope and wish that God will enlighten everyone to come together as one. I was raised from 2 very humble parents that were never educated. They never went to school. We had to teach them how to write their name. But the thing that they taught us was love. Love and faith, and never judge anyone by their color. Right. And I think if all of us can just embrace one person and tell them how important they are in this society, because I think all of us bring some kind of a value to society. And it doesn't matter how old you are, how young you are, we still learn from little children's behavior. I think we will really impact the world. And I just want to say that pulling together this incredible team for the Hippocratic, I saw so much love in everyone's face. And I do not believe that we are a unity of division. I believe that we are in a unity of love and supporting each other. So with that, I deeply thank you for being a part of us today and teaching us. And please keep up the great work. We needed treatment, and we need it yesterday, because if you get to know me, you will know that I like to do things yesterday, not tomorrow. So we need to have our gala. We need to raise a lot of money for cancer. It's something that it's affecting all of us and our families. I lost my mom from cancer. I've lost many, many friends to cancer. I've lost many of my friends' children to cancer. So with that, please keep up the great work. Find the cure, find the vaccine, find medicines, find anything that we need, because we have to do the gala on November 14th.
And stay
Thank you,
safe.
Eleni. Thank you so
Thank
much
you.
for
Thank
having
you all.
me.
Thank you,
See you
Doctor.
Before
soon.
everybody
Thank you.
goes, wait. Before everybody goes, I just have two quick announcements. Number one, we will not be doing the raffle today. Because of the uncertainty of the gala in November, we have to redefine some of those prizes and so forth. Number two, please join us this Sunday, June the 7th, for our Cancer Survivors Walk. It's this Sunday. It's a virtual Cancer Survivors Walk. More than ever, we all have to stay positive and provide hope for the cancer patients that we all, love and support. So see you on Sunday, and see you in 2 weeks.
Thank
Sorry,
you.
Nicole.
Thank you.
As I went
Thank
late, I
you.
couldn't connect. I thought you said that in the beginning. I'm sorry. Forgive me.
That's okay. Bye-bye.
Bye, everybody.
Bye.
Stay safe
Bye,
and healthy.
everyone.
So
God
much.
bless
Thank you.
everybody.
God bless you, everyone.
God bless.
Bye.
Thank you.
Bye-bye.
Thank you. Bye-bye.